All right, let's get right into it. Today, we're breaking down some compelling new real-world evidence on a clinical challenge we all face: how to prevent kidney injury from cisplatin. And for anyone who uses this drug, you know just how critical this topic is.
Okay, so here's our game plan. We'll start by really framing the problem. Then we'll dissect the study from Gupta and colleagues. After that, we'll dig into the results, talk about what this means for us in the real world, and then wrap it all up with the clinical bottom line.
You know, we've all been in this high-stakes situation. Cisplatin is an absolute workhorse, a cornerstone for treating so many cancers. But there's always that shadow of potential kidney damage, a major factor that can force our hand on dosing and scheduling.
So let's be really clear about the challenge we're trying to solve here. We're talking about cisplatin-associated acute kidney injury, or CPAK.
And CPAK isn't just a number on a lab report. It's a serious complication that directly messes with our ability to deliver effective, on-time cancer therapy. It really can worsen patient outcomes. So the big question is, what can we do to mitigate this risk? Well, a recent study published in the Clinical Kidney Journal by Gupta and colleagues looked at a really practical potential solution. Let's pull back the curtain on how they set up their investigation.
First off, this wasn't a small trial. We're talking about a huge, real-world, retrospective look at over 13,000 patients. They basically compared the group that got prophylactic IV magnesium on the day of cisplatin with the group that didn't. And they were looking for one thing: a difference in kidney injury or death within 2 weeks.
Now, this isn't just some random shot in the dark. There's actually a really strong mechanistic reason behind this. The theory is that low magnesium levels kind of mess with these key gates in the kidney. It opens one gate, ROCT2, wider, pulling more cisplatin into the cells, while at the same time it closes another gate, RMATE1, that's supposed to push cisplatin out. The result? You're basically trapping cisplatin inside the cells, and that leads to toxicity. So, supplementing magnesium could, in theory, fix this whole mess.
The mechanism definitely makes sense, but did it actually pan out in this massive group of patients? Let's take a look at what the data showed.
And here it is. This is the headline finding. Giving prophylactic IV magnesium was linked to 20% lower odds of that primary outcome, that combo of acute kidney injury or death. In our world, that's a pretty significant number.
But, the devil's in the details. This protective effect wasn't exactly the same for everyone. The data suggest an even stronger benefit in some specific groups: patients under 65, women, and our patients with diabetes. And, interestingly, those with better kidney function and higher magnesium levels to begin with. This really helps us start thinking about who might be the best candidates.
And here's the crucial part. This potential upside seems to come with, well, no downside. In this huge cohort, the magnesium was well tolerated and didn't cause any increase in adverse events. That's a big deal.
Okay, so that's the data. Now for the million-dollar question. How do we actually take this evidence and use it in our day-to-day practice? What does this mean for that next patient on your schedule who's getting cisplatin? We have to be good scientists here and look at this critically. On the one hand, the study's strengths are obvious. It's huge and it's real-world data. But we have to be honest about the limitations. Because it's retrospective, it shows an association, not necessarily causation. Plus, the outcome was based on serum creatinine, which we all know can be a pretty blunt tool, and it didn't really tell us anything about long-term kidney disease.
So all of this brings us right to the big question that every single one of us asks after reading a paper like this. Is this enough? Is this the kind of evidence that should change our standard protocols? Right now, practice is kind of all over the map. Some places do this routinely, some don't. But I think a large study like this really adds some serious weight to the argument for giving magnesium, especially for those patients you already tag as high risk, or maybe those with low baseline levels. It just might be enough to shift the balance. So let's boil this all down. What are the key takeaways for your next clinic day? What are the things you absolutely need to remember from this whole analysis?
Okay, 3 key things to take away. Number 1, the data points to a 20% lower odds of this really serious outcome. 2, this benefit might be even bigger in patients we see every day, like those with diabetes. And 3, when you weigh that potential benefit against how safe it is, how cheap it is, and the fact that the science behind it makes sense, it makes a really compelling case for at least considering this as a routine measure.
A commentary on this paper really put it perfectly. It highlighted that, yeah, we still need those definitive randomized trials, but the sheer weight of this real-world evidence is clinically significant. It's just hard to ignore.
And that really leaves us with a final, very practical question for the clinic. When you're standing there balancing a safe, cheap, and plausible intervention against a known and serious toxicity, what's your threshold for action? It's a question we all have to answer for our patients.